Welcome, and thank you for attending today's continuing education activity, Practical Considerations for the Use of GLP-1 Medications in Type 2 Diabetes. The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the Heart Association. The American Heart Association does not endorse any product or device. This session is being recorded and will be shared after the presentation. Please use the Q&A panel to submit your questions anytime during this presentation. Closed captions are available and can be engaged by clicking on the CC icon at the bottom of your screen. This presentation is a part of our offerings through Target Type 2 Diabetes. This quality improvement program provides support to organizations wishing to improve their diabetes care and outcomes with a focus on addressing chronic disease risk factors and provides an opportunity for award achievement and recognition. To learn more about Target Type 2 Diabetes and access resources, please visit the link in the chat. During today's call, our speakers will walk through the evidence for prescription of GLP-1 medications, as well as the pharmacist's role in diabetes management. After today's presentation, you should be able to identify evidence-based treatment algorithm for the pharmacologic treatment of type 2 diabetes, list 3 ways a clinical pharmacist can impact the care of a patient with type 2 diabetes, identify at least one source of relevant patient education materials, and select which patients are appropriate candidates for the use of GLP-1 medications. Next, I'd like to introduce our wonderful speakers. First, we have Nishant Shah, a cardiologist and associate professor at Duke University. We also have Michelle Chu, who is a pharmacist and assistant professor of clinical pharmacy at USC. Our moderator is Naomi Hamburg, a cardiologist and chief of vascular biology at Boston Medical Center. With that, I'll pass it over to Dr. Shah.
All right. Can you guys hear me okay? It's a pleasure to be here. I'm honored to be able to talk to all of you guys about GLP-1s, at least from a cardiometabolic prevention specialist standpoint. These are my disclosures, but again, the purpose of my talk is purely for educational purpose only. Next slide. So I have 3 objectives in my proportion of the talk. So one, I'd like to just review the role of GLP-1 receptor agonists and GLP-1 GIP combinations in patients with diabetes, introduce a new frontier of GLP-1 receptor agonists or GLP-1 GIPs when it comes to obesity management and non-diabetes related benefits. And of course, no drug would be effective unless we find ways to get it out to real world populations. And so I'd like to also just spend a little moment discussing barriers to implementation of novel therapeutics such as these in clinical practice and ways we can overcome those barriers. Next slide. So I'd like to start off with a case of just a patient that we may all see pretty regularly. So a 45-year-old female with a BMI of 30, type 2 diabetes, last hemoglobin A1C 6.7, hypertension, hyperlipidemia, comes in for just routine follow-up. She's tried everything, every effort to lose weight, but cannot. Her current medications include lisinopril 5 milligrams, amlodipine 10 milligrams, and metformin 500 milligrams twice a day, as well as sitagliptin 50 milligrams daily, along with a rosuvastatin 20 milligrams daily. Next slide. Another case is a 55-year-old male with a BMI of 35, has moderate sleep apnea, has hyperlipidemia, also just comes in for a routine follow-up on labs from his before he comes to his visit, shows a mild elevation in his liver enzymes, but otherwise his labs are unremarkable. His last hemoglobin A1C was 5.4, and his last LDL was 70 milligrams per deciliter. His only medication is rosuvastatin 10 milligrams, and he is interested in weight loss options. What do we do for these people? How can we discuss the next steps? So next slide. So, there are a lot of great innovations right now in the space of cardiometabolic disease, and particularly in patients with diabetes and other cardiovascular risk factors. Diabetes alone is a major risk factor for downstream cardiovascular events. And we're seeing a lot of momentum when it comes to novel therapeutics, especially in the SGLT2 inhibitor space, but in particular in the GLP-1 space as well. So I just put out three trials over here that you guys may be familiar with, looking at various GLP-1 receptor agonists. Leader looking at liraglutide, Sustain 6 looking at semaglutide, and the Surpass CVOT looking at tirzepatide. These are all in patients with diabetes, and you can clearly see that there's a benefit with GLP-1 or GLP-1 GIPs in patients with diabetes independent of BMI. So that has really put these agents on the map, especially for patients with diabetes who oftentimes have other risk factors. These are very helpful drugs for patients with diabetes. Next line. And if there's the data is so good that even in the American Diabetes Association management guideline, you can see that there is an early push towards both SGLT2 inhibitors, of course, but also GLP-1 receptor agonists to really help improve cardiovascular risk. Next slide. But there's more to this than just cardiovascular risk alone. There's also ways of indirectly improving cardiovascular risk. One of the huge discoveries of these agents is the impact it has on obesity. So this is just data from the STEP 1 trial, looked at semaglutide once weekly in addition to lifestyle interventions and placebo in overweight or obese patients without diabetes. And you can see here, compared to placebo, those that were on semaglutide had almost a 14.9% change in baseline weight, a weight loss from baseline. That is pretty impressive. And when you look across dose, there's clearly a dose dependent response when it comes to reducing the weight from baseline, which is very impressive and really started putting these drugs on the map as, is there something more than just improving outcomes in patients with diabetes? There's also profound weight loss benefit. And you can think about it as chicken and the egg, right? Like if you look at the hemoglobin A1C lowering potential alone of these GLP-1 agents, that's quite modest. But when you have the weight loss and you have other of the benefits, you actually have a net positive improvement in cardiovascular risk. Next slide. So what happens when you stop? A common question that comes up clinically. As far as we know in clinical trials, when people stop the agent, you tend to regain about 2/3 of the weight that you've lost, leading to a sort of a net 1/3 weight loss. However, that data comes from one of the STEP 1 extension trials, which looked at semaglutide 2.4 once weekly compared to placebo. Again, same patient population, right, as the study I just showed you. They extended the follow-up and they stopped the agent in some and continued in the others. And you can see the bottom blue line here that in those that stopped the semaglutide, you can see the weight regain. So important to keep in mind that as far as we know, these agents are meant for long-term use. Now, that doesn't mean you can't stop them, and every patient is different, right? People will do different things in terms of their lifestyle modifications, become more serious about weight training and all of these other things that may play a role in the amount of weight gain that people can expect when stopping the agents. It's not cut and dry, but in general, you can expect that there be at least a 2/3, more or less a weight gain if you stop the agent. Next slide. And not all GLP-1s are built the same. This is a plot comparing several different GLP-1s. And you can see here that, at least in terms of weight loss potential, semaglutide compared to at least liraglutide had a much stronger weight loss potential. Next slide. And this is just data looking at the weight loss in tirzepatide, right? We all know that these agents are great in patients with diabetes in terms of overall cardiovascular benefit, but look at the weight loss. Now, you can't really compare across trials. So I can't compare STEP 1 to SURMOUNT exactly direct, but I can make observations. At the lowest dose of tirzepatide, you had a similar amount of weight loss than the highest dose of semaglutide in STEP 1. So that goes to suggest that, is there a difference in terms of how well people do from a weight loss standpoint, depending on the agent they're on? All of them tend to lead to some level of weight loss, some more than others. And I think in general, clinically speaking, you want to, one, get what you can get for the patients because any weight loss is better than no weight loss, right? But we're starting to see, at least early on with the SURMOUNT 1, maybe some differences in the amount of weight loss. Some of that was, well, is the patient population a little bit different or what have you? This particular trial also enrolled patients that had a BMI of 30 or higher or a BMI of 27 with at least one weight-related comorbidity. So, and it did not have diabetes in this. So clearly there was a benefit in a non-diabetes population. Next slide. So the SURMOUNT-5 trial really sort of answered that question a little bit more directly, where they actually did head-to-head semaglutide to tirzepatide. And here in this particular study, they actually found when you compared directly, tirzepatide had a more weight loss potential than semaglutide, 21.6% from baseline compared to 15% from baseline. And again, this was a phase 3 open label control, randomized control trial in patients with obesity, but without diabetes. And they compared two of the higher doses of both tirzepatide, 10 or 15 milligrams, compared to 1.7 versus 2.4 milligrams of semaglutide. So really important trial when it comes to all of us clinicians out there in terms of understanding the differences in weight loss across agents. Next slide. So the question now becomes, we've seen a benefit with these agents in patients with diabetes. We've seen a benefit from a weight loss standpoint in these patients without diabetes. What else can these things do? Next slide. So I'd be remiss by not talking about the SELECT trial. The SELECT trial looked at semaglutide in patients with prior atherosclerotic cardiovascular disease and randomized patients to either 2.4 of semaglutide versus placebo, with the primary endpoint being major adverse cardiovascular events. You can see here that there were about 17,000 patients across the entire trial, and his patients just had to have a BMI of 27 or higher with no diagnosis of diabetes, okay? And again, primary endpoint was major adverse cardiovascular events, which I've listed over there. And what they found, as you can see based on the curves, was that semaglutide was superior to placebo in reducing incident CV death, non-fatal MI, and non-fatal stroke for a median follow-up about 40 months. And I think the other interesting thing here is that, yes, you did see weight loss in this trial, even though this trial wasn't powered for weight loss per se. But the benefit you saw in atherosclerotic cardiovascular disease happened much sooner than the weight loss, right? So the question then becomes, well, if the benefit from atherosclerotic disease is happening before the weight loss actually occurs, is there something about these drugs that's beneficial to the vasculature in our bodies, right? Is there some anti-inflammatory, antioxidant effects that these agents have? Is there some vascular benefit? And so that was really interesting, right? In that before the weight loss, you actually saw a difference in terms of between the two groups. Next slide. And just goes to show, again, supporting that hypothesis that maybe there's something else going on here. This is the Harmony Outcomes trial that looked at albiglutide, which is a little bit different, but still GLP-1 in patients with diabetes. Okay, they did a albiglutide versus placebo, and you can see here on the left there was a significant difference when it comes to major adverse cardiovascular events, almost a 22% difference between the drug and placebo. However, there was no difference in weight with this particular agent when compared to placebo. So goes to show, is there something else going on in these patients? Now, again, these were type 2 patients with type 2 diabetes, so a higher risk profile, right? But just again shows that these drugs seem to have profound benefits beyond just glucose control. They have cardiovascular benefits, obesity benefits, and so forth. Next slide. I'll just go through really briefly some of the trials here in the next few slides, just showing other benefits these drugs have had. So this is a SOUL trial looking at oral semaglutide versus placebo in patients with ASCVD and type 2 diabetes or CKD. And there was a benefit both in major adverse cardiovascular events and in major kidney disease events from the oral semaglutide version. Next slide. This is the FLOW trial looking at the use of subcutaneous semaglutide of 1 milligram versus placebo in patients with type 2 diabetes and CKD, and there was a benefit in terms of kidney outcomes. This trial was powered for the onset of kidney failure, which I've defined over here. But again, kidney benefits with these agents in patients with type 2 diabetes. Next slide. This is a STRIDE trial, specifically looking at patients with PAD. And they looked at semaglutide in patients with PAD and diabetes compared to placebo, 1 milligram, showed an improve in 6-minute walk and overall quality of life metrics. Next slide. There we go. And then there's also some HFpEF benefits with both agents, both semaglutide in the STEP HFpEF trial, which you can see in the left, both in the quality of life assessment and changes in weight. But then with tirzepatide in the SUMMIT trial, they looked at a composite of cardiovascular death and heart failure hospitalization, and there was a clear difference with tirzepatide compared to placebo. Next slide. Tirzepatide has also shown benefits in obstructive sleep apnea with better sleep apnea outcomes. Next slide. And then these are some ongoing ASCVD trials with tirzepatide. There's a SURMOUNT MMO that is going to evaluate cardiovascular outcomes in patients who are overweight or obese with ASCVD, kind of similar to SELECT, because most of the data I showed you in the ASCVD space has been with semaglutide. So stay tuned as there is data that is continuing to come with tirzepatide. Next slide. So let's just go into some practical pearls here. So I think the first step in terms of prescribing these agents is understanding the FDA indications and understanding what the payers are looking for. Because as many clinicians on this call know, those are two different things. You can have an FDA indication, but a payer may not approve it. So understanding the FDA indication is important when it comes to appeals and other things when advocating for patients. So for semaglutide and for tirzepatide, it's either a BMI of 30 or higher, or a BMI of 27 with at least one weight-related comorbidity. So that in the semaglutide group can include hypertension, diabetes, hyperlipidemia, and similarly that can be in tirzepatide. But tirzepatide has the component of obstructive sleep apnea as well on the label. Next slide. So you know the FDA indications, that's important for the first step, and that is knowing the indication. So the best indications that we have that most payers all agree on is any patient with type 2 diabetes, with or without ASCVD, or type 2 diabetes with chronic kidney disease. Most payers will be approving these agents. In those who have ASCVD, who are obese and overweight, we're starting to see more and more payers approve this indication, but there's still, you may see it less than patients with type 2 diabetes. This is coming from the SELECT trial that kind of really started that conversation. There's also MASH, or metabolic associated steatohepatitis with pretty much fatty liver, with moderate or to advanced liver fibrosis based on a FIB-4 score. And so that is also an indication for these agents as well. Next slide. So a couple of pearls on prescribing. Keep in mind some of the contraindications. Some of these are relative contraindications, but just keep that in mind. So patients with personal history of medullary thyroid cancer. Keep in mind side effects. Most of these are gastrointestinal, such as nausea, vomiting, bloating, constipation. But you want to be open about that with patients so they know what to expect. So we don't just give up right away, because oftentimes what happens is that they may feel that for the first few days and their body gets used to it and then they can tolerate subsequent doses. Keep in mind the risk of acute pancreatitis and acute gallbladder disease in the back of your mind, as those were mentioned on the label. Now, a couple of things I like to say, though, is that if you know that the cause of the acute pancreatitis, let's say, was triglyceride induced, right? But you're pretty confident there's no other cause of pancreatitis, that your triglycerides were the primary cause, and the triglycerides in part are driven by the obesity. That might be one indication where you can consider these agents. But if you don't have a known cause of how they develop pancreatitis, then I think you rather kind of take a step back, especially if it wasn't anything obesity related. So just be careful there. Next slide. So always remember to start low and slowly titrate up. So start at the lowest starting dose and titrate up every 4 to 6 weeks until you get to the max tolerated dose. I give some examples here. You can keep going. Can keep going. There you go. And then, however, you can also titrate the next dose based on the extent of weight loss, right? So you don't want somebody to lose too much weight all at once. And tolerability is going to be important as well. And then for drug switching, this data still needs to really come out there. But think about where you are in your titration with one drug, and then think about what would be the best equivalent. So, to be safe, what I do, this is just me talking in my practice. If I'm on like 1.7 of tirzepatide, or excuse me, semaglutide, I may start at like 5 of tirzepatide, or 7.5 of tirzepatide. Just go a little bit soft, but maybe not right away at the starting dose, if that makes sense. And of course, if you've not been on the drug for over a several weeks, then you might as well start fresh and start at the lowest dose of the next drug and titrate it over. Next slide. It's important also because of sarcopenia. This is probably the last point I'll make before we get into the question and answer, is that these drugs, there is some muscle loss with them, right? And there are newer drugs in clinical trials that are going to be working on, or be less sarcopenic, if you will. But we still need to learn about the safety and efficacy of those drugs. But what we typically recommend is patients do some level of resistance training while on these. Even if it's once a week, it's important to maintain lean muscle mass. Next slide. And here I just list a few barriers to implementation, right? Lack of insurance coverage, drug costs, provider inertia, drug availability, medical misinformation that impacts our trust. So you got to keep in mind what's going through the patient's mind a little bit, as well as other providers' mind, and so, it's important to understand these so that you can develop systems within your own practices to overcome these barriers. Next slide. Here are just some options. There's some direct options here. Lilly Direct for those that can't afford it versus Novo Direct. Next slide. The federal government also with the Bridge and Balance programs are coming up with agreements with all the different pharmaceutical companies to see if we can get these agents for significantly cheaper for our Medicare and Medicaid populations. Next slide. Oral Wegovy is now approved for commercial use, and their promos as low as $150 a month for one of the lower doses. Again, I know that is expensive still, but may be an option and significantly cheaper than when these drugs first came out for regular use. But these are all direct to consumer options. Next slide. Be careful with compounding. A lot of people go to compounding pharmacies to help, but these are not FDA approved agents. There could be ingredients in there that have not been studied, and really hard to determine the safety of this. So I would say I tend to gear patients away from this. Next slide. And then microdosing as well. There are a lot of concerns there. A lot of there's TikTok videos of people showing people how to microdose, have these like charts on here on how many clicks, but there's a lot of potential harm that can be associated with that. And so I put these slides out there to show that, it's important to have these conversations with patients and remind them what to be careful about. Again, not FDA approved how they do this. And so it's better to look for other ways of getting the agent to them rather than them going and listening to folks that may not be certified on the internet to give them guidance. Next slide. I think it takes a team. The way we do it is, we have a pharmacist that helps prescribe and titrate our meds for us. And it doesn't have to be a pharmacist, and you don't have to have a multidisciplinary team. You can just have a system in place that works for you in your clinic, where you can have either a nurse clinician, NP, APP, pharmacist, whoever you need to kind of help work with you in getting the patients on the max tolerated dose as soon as possible. Because we all know what the access issues are like in our individual clinics to get people back in clinic and then titrate. It may be months before they can actually get their maximal benefit. Next slide. So I'll go back to the cases, but maybe this may be a time for us to stop and moderate for time's sake. But perhaps what I can do, if there's a lot of questions in the chat, we can go through those, or I can just break these cases down, whatever our host and panel decide.
Well, thank you, Dr. Shah, for that amazing overview of the evidence for these medications and how to use them both in diabetes and obesity. And really, I think the point that these medications may have been developed for metabolic disease, but really have become cardiac essential components of our care for cardiac disease and prevention. Let's see, there are a couple questions from the audience, and then if we have time, we can go back to discuss the cases. So one is a question related to people who successfully gain weight. So if people's BMI drops below 27, I think there's questions asked both from the patient side and then the payer side. So from the patient side, do you stop it and then restart it with weight gain, continue it? And then what about if the insurance doesn't pay?
That's a great question, and I think comes up a lot clinically. My practice is to continue it because these agents were meant for long-term use, and in addition to the weight loss benefits, I'm also trying to get those cardiovascular benefits in these patients as well, and that can only continue if you continue the drug. Of course, the payer is always the one that dictates whether we can continue that or not, unfortunately. In my experience, if I have a justification on why we're continuing it, why they develop the weight loss because of the drug and that they've been on the drug regularly, or they have cardiovascular risk that warrants the use of the drug, or they have diabetes that warrants the use of the drug, usually have been successful. It really just comes down in documenting a couple of strategies that I've heard, or not heard, rather, I've seen work well. In addition to me appealing, I know none of us really have time for all that sometimes, but like patient appeals as well, I've found to be extremely impactful and effective, oftentimes more than my appeals when a patient reaches out to the payer. And so I've not had to go down that route for people on the agent already. Once it gets approved and they're on a stable dose, we'll continue to refill it unless they change coverages or their coverage plan changes. But I've not had a bad luck with that. Just keep justifying your rationale.
Great. Um, the next question is about the rate of weight loss. So we have the curves from the trials, which we know starts pretty early. What are your recommendations about how much the goal is for a given patient, and what if they're either exceeding that early on or not achieving it?
Yeah, no, that's a great question. So, in terms of not achieving weight loss, I'll tackle that first. It may just be they're not on their effective therapeutic dose. One, some people may need higher doses to achieve effective weight loss. The other thing I sometimes see is injection sites. Like some people just may need guidance on how to appropriately inject the therapy, depending on they're on an injectable or not. That could be the other. And some people I've seen are just truly not responsive to one agent, but extremely responsive to another. And so sometimes if they're not responsive to one, I'll switch to another to just see, do we get better luck? I think it's also important for patients to take on the lifestyle modifications we want them to, on top of these drugs as well to help augment the amount of weight loss. So I would say that for the ones that are losing too much weight, that's when you know your dose may be a little bit too much for them. I don't see that often at some of the lower doses, but I would say too much would be probably in like 2 weeks you lose over 10 pounds. That's like that is quite a bit. So I think somewhere in the 3 to 5 pound every 2 week range is probably safe to be conservative, but I don't think there's like a defined too much amount of weight loss that's too much. I think just how the patient feels going clinically on how they're doing probably is the best bet for you.
Yeah, and I also ask people about you want to make sure that they're maintaining their nutrition. And so, there are people who say, I can't eat anything, and that's not what you want for any of your patients. So, I think we still have to emphasize all the nutritional aspects of what's the benefits of certain foods are. Okay, next question. In this trial that of semaglutide that looked at the stopping and the weight regain, the question is what kind of counseling those people were getting at the time. And maybe I'll add to that my other comment about that I do talk to patients about is that, if you look in the placebo group where they're getting counseling, they're only about a 2% weight loss over time. And I still have a lot of patients who talk about have this sort of personal responsibility idea about it that they'll just keep trying and are reluctant about medication. So maybe I'll add that as our last question for this session.
Yeah, yeah, I totally agree with you. I mean, I totally agree. It's hard to know. This is one of the hardest things to standardize in clinical trials is like diet and counseling, and because it's so much of it is dependent on what the patient does, and it's hard to follow that in a clinical trial unless you're like have a camera on the patient, at all times, and so it's a good question. I don't think we can say conclusively, like, was the patient totally following the recommendations or not? It's so hard to know, which is why you take it patient by patient in the real world, right? Like if someone you feel is really good about like changing their lifestyle and things up, they may not regain that weight. We just don't know. This is the only data we have to go with. And I think if anything, it just gives us a conservative benchmark to be like, hey, if we stop it, we can expect this. If you don't regain that much, great. But I'll tell you, as a clinician, like I've stopped the agents on some people who don't want to continue them anymore just through shared decision making. And some people have regained the weight, others have not, and there's so many patient specific factors. It's so multifactorial. It's hard to know. You won't know unless you try, I guess. But there's other reasons too. I like to keep people on the drug, like those cardiovascular benefits as well, and the metabolic benefits. So it's a shared decision at the end of the day.
That's great. So I'll just say to the audience, please continue to put in questions. We will have another time for questions and answers at the end of the session, and now we will move to the next section. Thank you, Dr. Shaw.
Absolutely, my pleasure.
All right. Yeah, so I think that this would be a great segue to kind of talk about how pharmacists matter um, in the GLP-1 therapy. So thank you, Dr. Humberg and Dr. Shaw, for kind of leading the clinical part on the GLP-1. And now I'll talk more about just what the pharmacists do for the GLP-1 therapy. So this slide basically shows what I'm going to be covering, why pharmacists matter to improve access and navigation, patient education, optimize therapy, ensure safety, and reduce medication-related problems, and provide adherence support. And all of these can alleviate the workload of the team members of the for the clinic or the medical center, and they could definitely strengthen the collaboration with a patient as well as across the care team. Next slide. So one of the biggest real world challenges with the GLP-1 therapy is access, and as Dr. Shah mentioned. So because in practice, getting a patient on a GLP-1 is more about what the system allows. So I wanted to provide some quick framework based on the types of the insurance. Most plans, whether it's a Medicaid, Medicare, or a commercial, they will use three main tools, such as a prior authorization, formulary tiers, as well as a step therapy. But what this means is that even if you prescribe a GLP-1 or even dual GLP-1/GIP, the patient may not actually get it unless they meet the very specific criteria that the insurance is set. So let's start with Medicaid. There's a really important distinction here. So fortunately, diabetes coverage is mandatory across different insurance type, but they control the access very tightly. So almost all state will require prior authorization. So which means that you will need a documentations like A1C is greater than 6.5, or, like what's their current A1Cs, BMIs, and what other comorbid conditions they have. They also require step therapy. So usually require metformin to be started first. And each state has their own preferred drug. So it could be semaglutide, it could be tirzepatide, or it could be the liraglutide. So it really depends on how they negotiate with the drug company. Unfortunately, the obesity coverage is optional, and it is increasingly restricted. So as of early this year, 2026, only about 13 states cover the GLP-1s for the adult obesity under Medicaid. And several large states like California has removed the coverage. But even in the states that do cover, prior authorization is mandatory. The BMI threshold always apply. And they also require lifestyle program participation. Moving on to Medicare Part D, diabetes and cardiovascular indications, the coverage is very plan specific, but there's no universal like preferred drug. But in practice, usually semaglutide and tirzepatide are covered, but they are placed typically on the higher tier, tier 3 or 4, so it will cause more higher cost sharing. Um, as Part D structure is like it follows kind of the standard structures where there's a deductible and there's like a about 25% a coinsurance and there's like an annual out-of-pocket cap. But the drugs are expensive, so many patients will hit that cap within the first few months. So historically, Medicare has not covered the weight loss medications, but that is starting to change. So I'll mention very briefly, not on the slide, but we'll mention briefly two major programs that are coming. So the one of them, Dr. Shah mentioned earlier, it's a GLP-1 bridge program that will run from July to December. And it provides access to the weight loss medications of GLP-1 and the dual GLP-1 and GIP. It provides about like a $50 monthly copay, which is a flat fee. But unfortunately, this is not counting toward the annual out-of-pocket cap. So that's something to consider. The second one is the balance model that is going to start in 2027. And this will allow Part D plans to cover GLP-1s for obesity at negotiated price. So patients will need to enroll during the open enrollment during 2026. They have to specifically enroll in a participating plan. But eligibility is very strict. So BMI is 35 or higher, or if they have, comorbid conditions, it might be slightly lower. Lastly, the commercial insurance, it's very variable. So for diabetes, coverage is almost universal, but for obesity, it's very patchy. So only about 19% of the mid-sized employers will cover the GLP-1s just for the weight loss. And many plans usually just exclude weight loss drugs entirely. So if we're stepping back and kind of think about what the few key realities are, is that most GLP-1 denials are administrative. Maybe same patient who was covered by one drug may not be covered under another. The indication, Dr. Shah mentioned this again, the indication is very, very important, and that's probably the single biggest determinant of approval. So the role of pharmacists is really we kind of act as like a bridge between the clinical appropriateness and then the actual access. We can help justify the exceptions, maybe the poor A1C control, the preferred drug, need for greater weight loss or intolerance. Maybe there's a specific cardiovascular indications. In practice, we might have to also sometimes cycle between the agents based on the coverage because, the plan preferred drugs or their covered drug might be different from plan to plan and as well as year to year. And then, there are definitely alternative access options like cost plus drugs, a good RX, a Trump RX. So those kind of things we can definitely help the patient and the clinic, the providers with. Next slide. So the second area that the pharmacists are valuable is in managing GLP-1 therapy optimization. We have some titration strategy where we basically trying to minimize the GI side effects and also managing those GI side effects, but at a more slower titration. And there, you don't always have to rush to the max dose. So it's completely appropriate to even hold at an intermediate dose. So we're trying to find that best tolerated effective dose for the patient. Again, it might come up more often than people expect. That's you might have to switch between GLP-1s. Maybe it's because of the tolerance issue. They might be intolerant to one medication versus the other. Maybe they are reaching the plateau, so inadequate clinical response to one medication, so they will have to switch to different one. Or it could be, again, the health plan coverage might have changed. So we might have to, interchange between these medications. Also, switching from the subcute to PO, that we can definitely help with that. And when you think about the pharmacist, we kind of think of just straight about like just medications, but we also look at the patient as a whole. So not just the A1C, not just the medication or GLP-1 itself, but we're looking at the whole treatment regimen and their comorbid conditions as well. So we might prioritize the different medications based on their comorbid conditions. So if the patient has the clinical ASCVD or they are at high risk of ASCVD, definitely GLP-1 would be prioritized. If the patient has a CKD or maybe they have the albuminuria, we might consider SGLT2 inhibitors first or in the combination with a GLP-1. So, and if the obesity is a major, driver of their current disease states, then may consider trying to targeting the higher dose of GLP-1 options. Next slide. The next area that the pharmacist can be valuable is looking at the safety of a GLP-1. So at the high level, most clinically relevant interactions with the GLP-1 receptor agonist come from two main mechanisms. So first one is the additive glucose lowering effects. Pharmacists will pay attention to these additive glucose lowering effects when GLP-1 is used with other medications, and we may be able to de-intensify the medications regimen by reassessing the rest of the medication. So in particular, something that comes to my mind is a sulfonylurea and insulin. Those medication may need to be stopped or reduce the dose. The second one is the GLP's property of delayed gastric emptying. So it can affect both the food and medication, how long they stay in the stomach. And it is beneficial actually for glucose control because it will blunt the post-meal spikes. But from a medication standpoint, it can create some challenges. So like other drugs that are taken together may have some effect on their delayed onset, or maybe their peak levels might be lower than expected. So not that it is contraindicated, but the medication that has a narrow therapeutic window, such as like warfarin, you might need to monitor the doses as well as the INR. And if the patient is using the oral contraceptive, it is known that their exposure is decreased by about 20% when they are taking it with tirzepatide. So always want to increase the backup method and or maybe switch to non-oral options. So particularly, like 4 weeks after starting therapy or 4 weeks after dose changes. And obviously, because of this, the property of slowed gastric emptying, if it's not stopped, at least the 1 week before procedures or surgery, it may, lead to some escalations during the anesthesia. And if the patients are taking the GLP-1 oral medication, like a semaglutide oral, then you might want to separate out with other medication about 1 hour before or 4 hours after. There are also some serious GI symptoms that we can monitor that could come from, different mechanisms like a gallbladder disease or a gastroparesis, pancreatitis. But basically, if there's like any severe abdominal pain that radiates or the right upper quadrant, pain after meals or severe nausea and vomiting, then the pharmacist can definitely triage and appropriately refer back to the providers. Next slide. So Dr. Shan mentioned about the compounded GLP-1, and as you know, this trend really emerged from like increasing demand as well as a drug shortage. And then also it's not only that, it's also kind of because of the cost barriers for the patient. So they started to look for the alternatives, which was came down to the compounded GLP-1. But what is compounding? So at its core, compounding is a preparation of the customized medication by a pharmacy. It typically includes for the GLP-1 is a semaglutide or tirzepatide. It is usually done by two different pharmacies. So there's a type 503-B pharmacy. This is not your traditional compounding pharmacies. These are allowed to produce in bulk and only during the official drug shortages. So you can kind of think of it as like a manufacturer. These are the manufacturer. They make it in large bulk. And then usually they will supply to the clinic or the hospital directly. The 503A pharmacy is the traditional, compounding pharmacies. And then they compound based on the individual prescription, and there has to be a clinical justification. So, and everyone's doses and how they compound it will be different. They cannot mass produce and they cannot copy the commercially available products. So in practice, they will usually use kind of a salt form. So for example, semaglutide sodium or semaglutide acetate. But that becomes more of a regulatory issues. So now that the regulators, they have asked to seize the distribution of that. And this salt form is not the same as the FDA approved active ingredient. Also, because of this individualization of the compounded GLP-1 from the 503A pharmacy, they often add some formulations like a vitamin B12, or maybe they might change the delivery form. But the problem with this is that it's not safe only because the stability and the purity, all of these are not really regulated. So that's why the pharmacist can really help the patients to evaluate the legitimacy of the pharmacy and the ingredient that they use. We can always counsel the patient that this is not the same as an FDA approved product. And definitely the dosing might be very different. The injection might be different. They may not come in as a pen. They might need to be reconstituted. So there might be some dosing errors. And again, the lack of standardization is definitely the potential risk is involved there. If the patient is finding the compounded GLP-1 with like extremely low prices or online only prescribers or pharmacies, that might be sort of like a red flag and might need more further investigation. If the labeling is not very transparent of what kind of ingredients they are using, it also might be the red flag. And definitely at the end of the day, pharmacists will advocate for the safer alternatives, which is kind of transitioning back to the FDA approved products and helping with the insurance navigation and prior auth. Next slide. So, through helping with the drug access, therapy optimization, monitoring, and making interventions for safety and efficacy, these all, in turn reduce the medication-related problems. So one of the two things that we see is the early discontinuation and the lack of efficacy. So it's really important to set the right expectation with the patient, especially with the timeline with the transition and the dosing titration, how much of the glucose, clinical benefit is going to see for how long. And then in terms of the side effect, the common and temporary GI side effect, it should be sort of normalize that experience. So obviously the severe nausea and vomiting is not, but patients should be expecting some very mild nausea, early fullness, or maybe some constipation in the beginning or diarrhea. But the key message is that these are usually temporary and manageable. So it's not the reason to just stop the drug right away. But we can provide an advice to eat smaller meals or avoid high-fat foods, eat slowly, stay hydrated. So these are kind of the educational points that we can provide. With the starting of these medications, another major shift is really appetite changes. So, we need to just kind of coach them through, stop eating when full, when feeling full, and don't push through it. Also the, dosing expectation is really important. So we always want to start low and go slow approach. So the titration for the initial one at least can happen even, 4 weeks or even longer, 4 to 6 weeks. So the patient just needs to understand that the, starting dose may not be seen with any clinical effectiveness, but then that's more for the tolerability, and then we will move on. The lack of efficacy really comes from the patient factors or access issues. So many times my patients, I work currently at the county facility, and many of my patients, we find out that they only dial about 2 clicks of the, for example, semaglutide pen, thinking that that's their starting dose. They don't dial all the way through 0.25 milligram on the window. And these usually happens with the patients who have been using insulin pen, because every single dial or click, they consider it as a dose. So they sort of like guess, they don't know, but then they sort of guess that, okay, I heard 2 clicks and maybe a half, and then they think that's a starting dose, for example. So these kind of things that really will need the education. There might be, whether it's the personal issues or the insurance issues, refill gaps might be happening, missed doses, and then obviously there's some respondent difference in the responding rate. Next slide, please. So I think I sort of like covered all the patient education. On top of that, we will talk about the diabetes management, and we're more focusing on the diabetes with the GLP-1 here. So, there's a various aspects on the adherence support would be provided by the pharmacist. And next slide, and I do want to actually provide this case example. I want to credit my colleague, Dr. Gurvich, who is practicing at the senior center. And next slide. And this case is really talks about how the access issue comes in. So this is a 65-year-old with a history of hypertension, osteoarthritis, hypothyroidism, obesity, and constipation. This patient started as tirzepatide in January 2025, and they were able to successfully, titrate up to 7.5 milligram as of July 2025. And then at the July 2025, at the time, the BMI is still 54. And then next slide, please. And they hit the plateau, the weight. So far from January to July, this person lost about 65 pounds, but then weight plateau. So they decided to increase the dose from 7.5 to 10 milligram in January 5, 2026 this year. So again, with the year change, everything about the insurance changes, right? So they sent the PA, the prescription, thinking that it would be covered, but it wasn't. So they required the PA to be submitted. So then the very next day they submit the PA, and then it was immediately denied because the insurance company is requiring the patients to participate on their own online weight loss program. So 2 days later, so January 8th, patient is calling the office, and then she's really worried, right, throughout the whole process, that she doesn't want to restart the whole process again. And then in January 12th, the clinic speaks to the insurance company, and then finally gets the confirmation that the patient is enrolled in their virtual weight loss program. Oh, I'm sorry. So they didn't actually find the confirmation. So they needed a confirmation, and they said a patient is not enrolled, but when patient said that they were enrolled. So there's a lot of different conversation. And then on January 14th, finally, they were able to confirm the patient is enrolled. So they submit the PA right away the next day. So that's like January 15th. And in January 2020, the PA gets denied because they need an evidence that patient has lost about 5% of her weight since the baseline. So then there was a lot of disputes, and documented had to provide it. So finally on January 30th, the PA is approved. And February 2nd is when the patient was able to pick up the medication. So you can see the timeline, how long it took with insurance. Next slide. So then I think the question really comes down to, well, how can we collaborate with the pharmacists? Because, maybe this type of work might be kind of new to other non-pharmacy colleagues. So the next slide. So, you can hire them directly, whether you are from FQATC or medical center or community health center, you can hire them. When you are hiring them, you could definitely set up the collaborative practice agreements. There are some states that allow for pharmacists who holds a special licensing. They don't really need a CPA, the collaborative practice agreement. They could actually independently help with the patient management for the comorbid conditions. So you don't really need a CPA, but other states that doesn't have that type of licensing, you may need to establish the CPA. If that's a difficult, you can always partner with the community pharmacies. There are a lot of community pharmacies who provide these type of services, and I don't think a lot of clinics know about this. And then you don't have to hire directly from them. You can just set up the CPA without hiring them. And then you guys can definitely collaborate on the patient care. And then other avenues could be partnerships with a pharmacy school. So for example, my pharmacy school, we have a partnerships with the different FQHCs. We train the staff, and then we basically supply the staff, and then the staff is working at your FQHCs. So it's kind of that type of partnership where we are able to kind of guide the staff pharmacists in the clinical making decisions as well. So there's different ways to do that. So I will end my talk here. And any questions that I can answer, I'll be happy to remain online.
Thank you so much. I have to say that when I started giving GLP-1, I was trying to do it without any pharmacy support in our cardiology practice, and it was really hard, especially with all the addressing side effects and titrations and prior approvals. And it's just been a critical component using these medications as a team, whether that's with the diabetes pharmacists, or in our practice, our cardiovascular pharmacists have gotten extra training to be able to do GLP-1. So I highly recommend doing that as you're working on this. In terms of other questions, I've been working on answering all your great questions in the chat. Maybe I'll just ask a more general question that addresses some of them in terms of side effects, which you addressed to some degree. But in terms of side effects, how do you think about when it makes sense to still do a dose titration or not, is one question. And then the other is, I think with all the publicity about these agents, a lot of times there are side effects that come up that weren't necessarily reported in the trials. And how do you address those questions from patients?
Yeah, those are good questions. I think it really has to do with the severity and close monitoring of the patients, their symptoms, as well as how their lifestyle is like what kind of modifications they are employing upon starting this medications. A lot of patients, they think that because they are on this medication, they can still continue their old habits. But, once they do that, they will feel this more prominent GI symptoms. So then usually what in my practice, we would follow up with them every week, actually, once they start, and then always ask them about the severity of or the level of the symptoms that they're experiencing. Usually it will go down. And then some of the things that they come up, the topics that come up is most of the patients are just really concerned about the GI symptoms and then the muscle loss. But muscle loss also kind of comes with a fast and quick weight loss as well. So I think it's just important to just to educate the patients on how important the protein intake is in their diet, as well as resistance training is also important because you don't want to lose that muscle either. So I think just keep talking to them and honestly, really, really like you are being a coach. You're sort of like started out with like a pharmacist and then kind of becoming their like a coach, and then we are actually going through their life journey together. So it's yeah, that's how we usually manage.
Well, and I think that's a great point to close on and hand back to Megan to close out the session.
Thank you so much to our presenters for their thought-provoking presentations today. Provided on the slide is a QR code that you can scan to claim CE credit for this event. A link will also be provided to you in the chat so that you are able to claim the credit. As GLP-1 medications reshape type 2 diabetes and weight management, we still lack real-world insight into long-term patient experiences. The American Heart Association's Healthy Living Beyond Weight study captures how patients manage weight across GLP-1s, lifestyle, and bariatric surgery, focusing on outcomes that matter beyond weight loss. You can invite eligible patients to participate and help strengthen patient-centered, evidence-based care. Please go to heart.org/go-beyond for more information. We are here to support your organization in their quality improvement journey. Get connected with us to access tools and resources, connect with one-on-one support, and celebrate your team's success with awards. Thank you for attending today's presentation.